with you this evening talking about genetic testing and pregnancy. A genetic counselor helps you decide what's right for you. My name is Laura Herscher. I'm a genetic counselor and a faculty member at the Joan H. Marks Graduate Program in Human Genetics at Sarah Lawrence College. I'm here this evening with Blair Stevens. Blair's at the McGovern Medical School at the University of Texas Health Science Center at Houston and Children's Memorial Hermann Hospital Fetal Center. Blair has witnessed the evolution of prenatal testing over the past decade and helps patients navigate their testing options every day in clinic. So we're both here today to talk with you about genetic testing and pregnancy. First though, just a little bit of business. We encourage questions to be asked throughout the presentation. If you have any questions you would like to ask us, click on the question and answer tab and type a question into that box. Questions submitted will be read aloud during the question and answer portion of this presentation. By submitting a question, you are consenting to have information contained read out loud during the presentation. Please do not submit any personal identifiers in your submission. Please note, as a courtesy to the presenters, all participant phone lines have been muted automatically. If you should experience technical difficulties during this presentation at any time, use the question and answer tab to submit any concerns to us. NSGC offers a wide range of educational programming. The information provided in this presentation is not a substitute for medical or professional care, and you should not use the information in the place of a visit, call, consultation, or the advice of your physician, genetic counselor, or other healthcare professional. So, the number of genetic tests that are offered to women who are pregnant or thinking about becoming pregnant keeps increasing. And that's really wonderful because it gives women more choices. And for many women, most women, it offers either reassurance or the opportunity to ensure that they give birth to a healthy baby. But what's right for one woman may not be right for another. And all those options can be terribly confusing. Hopefully, we can sort out some of that for you tonight. For the first part of this webinar, I'm going to put myself in your shoes and get our expert Blair to answer some questions about what these genetic tests can and can't tell us. Then we'll give you some examples, and Blair and I will talk through how each person's story might affect the decisions they make about testing during their pregnancy. So Blair, if I'm not pregnant yet, but I'm thinking about it, is there any testing I should do?
So my first step is to tell you it's great that you're thinking about this already. In the ideal world, you want to ask these questions before you conceive so that you have more reproductive options in front of you. So before you get pregnant, in the ideal world, you would go and see your genetic counselor or your OBGYN and just talk about any relevant family history that you might have. For example, if you have a family history of a birth defect, an intellectual disability in a family member, or a specific genetic condition, there might be very specific testing that we would recommend for you before conceiving. Sometimes there are not genetic tests available for every condition, so it might just be a conversation so that you understand what exactly your risks are for having a child with the same condition that's in your family.
So what if there is nothing in my family history? Do I still need testing?
There are certainly options that are still there for you because it's a very common misconception that all genetic conditions run in families. And so if your family is healthy and you're healthy, there's really no need for genetic testing or genetic counseling. But that's just not true. There is what we call carrier screening that we offer anyone considering pregnancy. And that's because some of these conditions that are genetic run in families silently. So you wouldn't necessarily know that they existed. And people that carry these silent conditions are what we call carriers. And we know that everyone carries genetic conditions, even if they're perfectly healthy, because carriers have no symptoms of the genetic condition. And we probably all carry a few different genetic conditions, but for the most part, most of these conditions are not something you have to worry about unless you and your partner carry them. And so for these reasons, we offer carrier screening to anyone. And there's a variety of different carrier screening options. For example, you might just get offered screening for common conditions, such as cystic fibrosis, sickle cell anemia, or spinal muscular atrophy. Because they're more common, we offer them as a basic panel. But your doctor or genetic counselor might also recommend additional conditions based off of your ethnicity or ancestry. For example, Ashkenazi Jewish individuals are at a higher risk for more conditions such as Tay-Sachs. And then finally, there's an option called expanded carrier screening. And as genetic testing has gotten less expensive, we've realized that we can test for more and more things. And so you might get offered expanded carrier screening, which could be well over 100 different conditions. And we can offer that testing to anyone regardless of their ancestry or ethnic background. Now, most of the conditions on carrier screening panels are what we call recessive or autosomal recessive conditions. And what that means is that the only way that your pregnancy or children would be at an increased risk is if you carry the condition and your partner carries the condition and you both pass down that genetic change. So just to give you a little bit more background on that, in most genes that we have 2 copies. We have 1 copy that comes from our mom and 1 copy that comes from our dad. So these little blue bars are representing the 2 copies of that gene. And we know that in this couple, they each have their 2 copies. And let's say that this couple wanted to undergo cystic fibrosis screening. So this lady, we'll name her Sue, decides to get cystic fibrosis screening, and bam, she comes back positive as a carrier. Well, like I mentioned, we all carry genetic conditions, so no need to be alarmed at this point, but it does make us want to test her partner. We'll call him Tom. So if Tom gets testing and he screens negative, we're very, very reassured that their pregnancy would not be at risk because, like I mentioned, both partners need to carry it to be worried. It's not a 0 chance, though. They're not completely in the clear because carrier screening is very good for some conditions at least, but we know that it's not 100% accurate. So if Tom screens negative, that's a great deal of reassurance, but there's still a tiny chance that maybe we missed his genetic change and that they could still both pass it on. So carrier screening is not 100%.
If it's positive, is it 100%?
It essentially is 100%, but that's an important thing to talk with your doctor about because there are some laboratories that do more expanded testing for these genes, and they're rarely, but there are times when we can find a genetic change that we think is most likely, meaning they're a carrier, but not definite. But for the most part, with carrier screening, a positive result is a definite result. That's a great question, and definitely worth conversations with your provider when they are ordering which test. But let's say that Tom does get a positive result, and it's one of those results that we know is a certain positive. So now this couple is at increased risk, knowing that they both are carriers, but not every child that this couple has will have cystic fibrosis. So as I mentioned before, it's only if the mom, Sue, passes it down and the dad, Tom, passes it down, will that child be affected with cystic fibrosis. If either couple passes down their other copy or both pass down their other copy, that child will not be affected with cystic fibrosis or whatever condition that they screen positive for. So just as an FYI, carrier screening can often start with one partner, but then if that partner does screen positive, we have to end up testing the other partner. And the more genetic conditions you screen for, the more likely you are to find what you carry. Because like I said, we know that everyone carries at least one, probably more genetic conditions like this.
This sounds like information that a lot of people would want to have. What if I'm already pregnant? Is it too late for carrier screening?
Absolutely not. You can do carrier screening at any point in time. It's actually testing your genetic information, and so that's going to be the same whether you're pregnant or not pregnant. In the ideal world, we would recommend it before pregnancy because there are several reproductive options you can pursue if both parents are carriers, or if your pregnancy is at risk for something. And if you're already pregnant, some of those options are off the table. So ideally, you'll do it before pregnancy, but you can absolutely do it at any point in time during pregnancy as well.
Besides carrier screening, what else do we test for during pregnancy?
So there are a lot of testing options that we now have in pregnancy. Back in the day, you just got pregnant, hope for the best, had the baby, figured it out after delivery. Nowadays, we have all of these testing options that we can look into health information while you're pregnant. And we can't test for everything. There is no genetic screening test or diagnostic test that can look for everything. So what we focus on are for sporadic conditions that can just happen by chance and therefore happen to everyone. And we offer everyone screening for these types of conditions. And they're what we call chromosome conditions. So chromosome conditions involve having too much or too little genetic information, and you might be familiar with the most common chromosome condition we call Down syndrome. The risk for these chromosome conditions is present in any pregnancy, but we do know that the mom's age at the time of pregnancy does impact that risk. So the younger you are, the lower your chances are of having a baby with a chromosome abnormality. The older you are, the higher your chances are. But there's a chance at any age. So once again, we offer this screening to everyone that's pregnant. So this is probably more information than you guys actually need, but I just wanted to give you a little bit of background on chromosomes so it'll help you understand the differences between some of the screening and diagnostic tests and what some of these conditions are. And I assume if you're watching a webinar on genetic screening and testing that you're probably an information seeker. So if you recall or heard of chromosomes, this is a picture of what chromosomes look like. And chromosomes are inside every cell of our body. They contain all of our genetic information or our genes, and we get them from our parents. So our dad gives us 23 of his chromosomes, our mom gives us 23 of hers, and that's why you see them in pairs. We get one from mom, one from dad. The first 22 pairs are the same in everybody, but the last pair are called our sex chromosomes, and those dictate whether we're male or female. So females have 2 X chromosomes, or if we're looking at a male's chromosomes, we should see an X and a Y. So as I mentioned before, when we were talking about chromosome abnormalities, we're talking about having too much or too little genetic information. And the most common chromosome condition is Down syndrome, which involves an extra chromosome number 21. So if you're familiar with Down syndrome, you know that these kids are more like other kids than they are different. But because of that extra piece of chromosome, they do have an increased risk for certain birth defects, such as a hole in the heart, or certain health concerns after delivery. They do hit their milestones, but they tend to do it at a later time. And they also have intellectual disabilities. Now, I think this is a good point to kind of interrupt myself and mention that while we can test for Down syndrome in pregnancy, if we get this picture, we can tell for sure that a baby might have Down syndrome, but what we can't figure out before delivery is the severity of Down syndrome. If you have met people with Down syndrome, you might have noticed that there's certainly a spectrum. Some kids are more severely affected, some kids are less severely affected, but they almost all of them have the same exact chromosome makeup, so we wouldn't be able to predict where on the spectrum a child may fall by just doing prenatal testing. So something to keep in mind as we discuss the test options. Now, another condition frequently tested for in pregnancy is called trisomy 18, and then we can also test for what's called trisomy 13. So having an extra chromosome 18 or 13 is a much more severe condition than Down syndrome. These babies typically have multiple birth defects, often severe birth defects. Many of them will miscarry during pregnancy or pass away the first year of life. And if they survive past the first year, they often have severe medical and developmental problems. These are more rare than Down syndrome, but like I said, much more severe. And in addition to these chromosome conditions, there are some additional ones that are much more mild that involve having an extra or missing X or Y chromosome. And then there are many additional chromosome conditions that don't involve a whole extra or whole missing chromosome, but maybe a smaller piece of the chromosome that could be extra or missing. But generally speaking, Down syndrome, trisomy 18, and trisomy 13 are the main ones that we focus on for prenatal testing.
Blair, you've mentioned a couple times that there are different types of tests. Can you tell us more about them? How are they different?
Absolutely. So there's plenty to choose from, and part of the job of a genetic counselor is to help you navigate those options. So we're going to try and break down for you and simplify them to hopefully get you guys an introduction to what these tests are so that you can go to your OBGYN or genetic counselor for more information. In general, there's 2 types of tests. There's what we call a screening test and a diagnostic test. Screening tests are safe. They are commonly blood tests that may or may not involve an ultrasound as well. The screening test results are not definitive. So if you come back with an abnormal blood test result, that means that your chances have increased for that genetic condition, but it does not mean your baby has that condition. Whereas a normal result reduces and reassures us, but it doesn't rule out the condition altogether. Furthermore, there's only a set number of genetic conditions that a screening test looks for. It can't test for, many genetic conditions, but it looks at usually the more common ones. Whereas if you do a diagnostic test, that does require an invasive procedure, so something that goes into the pregnancy to get a sample to test, and that provides us with many more options. So we can do more definitive testing. These types of tests will give you more of a yes or no type of answer, and it allows us to test for more genetic conditions. So it gives you more information, it gives you more accurate information, but it does have the setback of having that risk of invasive procedures.
Okay, let's start with prenatal screening.
Okay.
Are all prenatal tests basically the same?
So not really, but they're often confused with each other, and it's understandable why, because most of them are blood tests, and if you've ever been pregnant, every time you go to the OB, they draw a bunch of blood, and so sometimes it's hard to know what you're getting tested for, but it's really important to know the differences between these tests, and so hopefully this will help. In general, there's two main types of screening tests, what we'll call maternal serum screening and cell-free DNA screening. They have many different names, and so there's many different types, but and that can make it more confusing. But in general, maternal serum screening in general, both of them are going to tell you information about the pregnancy for Down syndrome and trisomy 18, but depending on which test you choose, there might be additional conditions above and beyond those two. Both of them involve blood work. Both of them are going to catch the majority of pregnancies with Down syndrome and trisomy 18, but not all of the cases. Both of them can give you a false positive, which means the test comes back abnormal, but the baby does not have the condition. So there are a lot of similarities, but let's kind of dissect them further to look at the differences. So maternal serum screening, you've got options such as the first trimester screen, the quad screen, the integrated screen. These are all just various ways of doing a similar test that the blood work is looking at hormones. So when you're pregnant, the pregnancy and the baby are producing hormones and proteins, and some of those get into mom's circulation. So we can draw mom's blood and get a sneak peek at what's going on with the pregnancy by measuring the levels of these hormones. Generally speaking, babies with these chromosome conditions should make different levels, and so if we see that pattern, we'd be more concerned. If we don't see that pattern, we'd be less concerned. Cell-free DNA screening, on the other hand, takes advantage of the fact that when you're pregnant, DNA or genetic information from the baby's placenta is shed into the maternal circulation. So we can do a blood test and look at the DNA from the pregnancy and see if we think that there's a higher chance or a lower chance for a chromosome condition. As you can imagine, if a pregnancy has an extra chromosome, if the baby has that, the placenta should have an extra chromosome, and therefore the woman's bloodstream should have extra amount of that chromosome floating around. Now, you might have heard of DNA screening by different names, such as non-invasive prenatal screening or NIPT, non-invasive prenatal screening or NIPS, and there's many brand names that you might also hear it called by, but it's all essentially the same test.
Sort of the new one, right?
I'm sorry?
It's the new one.
Exactly. It's the new test, or what we'll later talk about more, but the gender test or the DNA test. So it's like I said, it can be very confusing because we give everything in medicine 18 different names for the same thing. But what we found is that cell-free DNA screening is more accurate for conditions like Down syndrome and trisomy 18 than maternal serum screening. But in addition to accuracy, there's some other important differences. Some are just logistical, such as timing. DNA screening you can do any time after 9 to 10 weeks of pregnancy, whereas there's a little bit more stricter time frames with maternal serum screening, but those are still both available in the first and second trimester. Insurance is the big question my patients ask me. Is insurance going to cover this? For maternal serum screening, the answer is almost always yes. It's a cheaper test. It's been around for a long time. Insurance, usually is not an issue for maternal serum screening. Cell-free DNA screening, it's not as straightforward. Some insurance companies will cover it for every pregnant woman, regardless of her risk factors. Other insurance companies will only cover it if there is a risk factor, for example, being 35 years of age or older, or a previous child with Down syndrome. So it's important to discuss insurance coverage with your insurance company, or you can ask your genetic counselor or OBGYN for guidance on that. The other big thing, which I alluded to earlier, many people get very, very excited to find out the sex of the baby. And while most people find out at the 20-week anatomy scan, cell-free DNA screening does give you the ability to find out earlier, since we can look for the X and Y chromosome in mom's blood. whereas maternal serum screening does not test for the sex of the baby. But I would like to put in a plug that this is not the gender test. It is a test for chromosome and genetic conditions. And the kind of icing on the cake is that you get to find out information like gender. And then to go back to accuracy, we decided not to, give you a whole bunch of statistics because there's often differences in the detection rates and the false positive rates depending on which lab you use or which particular type of test you use. And so bottom line is they detect most cases of Down syndrome. They both have false positives, but we thought we'd give you a kind of a case example to demonstrate some of the differences in the accuracy of these two types of tests. So let's say, for example, we've got a pregnant 30-year-old woman. It's her first pregnancy. She's trying to figure out which type of screening test she wants, but she knows she wants a screening test. And let's say that she chooses to do maternal serum screening, and it comes back negative for Down syndrome. Well, as we know, this test isn't perfect, so there's still a small chance we could have missed Down syndrome, but the chances for her after a negative maternal serum screen is well less than 1% that we missed it, so very reassuring. Mind you, she's 30 years old, so her risk for Down syndrome from the get-go was less than 1%, but now it's even more less than 1%. Let's say, however, she decides to go the cell-free DNA route and gets a negative result from that. Well, what are the chances we miss Down syndrome with that result? It's still well less than 1%. And it's an even little less, more or less than 1% than her maternal serum screen result. The bottom line is, especially for a low-risk woman, a negative result is very reassuring with either screening test. So there's not a humongous difference when you're talking about well less than 1% type of numbers. But on the other hand, let's look at positive results. If this same pregnant woman had a positive serum screen result, and these numbers will vary depending on her specific hormone levels or what type of test she had. But for this example, let's say that she had a positive maternal serum screen and the test came back saying that there is an increased risk for Down syndrome and that risk is 3%. Well, that is much higher than she started, but that also means there's a 97% chance she's what we call a false positive and that her baby does not have Down syndrome. She just screened positive and has a unaffected pregnancy. So 3% chance it is Down syndrome, 97% chance it's not. If that had been a cell-free DNA test and it came back positive for Down syndrome, we're much more concerned. When this type of referral comes through my desk, I'm much more worried that maybe this is real because there's a far lower false positive rate with cell-free DNA screening. So after crunching the numbers for her, we find out that a positive cell-free DNA screening gives her a 60% chance that it's actually Down syndrome and a 40% chance that it's not. So this is much higher than her 3% chance she would have gotten with a positive maternal serum screen. So negative results, both reassuring, positive results, pretty significant difference in what that means for a pregnancy.
Either way, both of these women after a positive result would be given the option to go on to diagnostic testing, right?
Absolutely.
Yeah.
So no matter.
Let's talk a little bit about that alternative, diagnostic testing.
Perfect. So diagnostic testing is available to a woman that has gotten an increased risk result from her screening test because no matter if it's a 60 or 3% chance, there's a chance. And until you do a diagnostic test, you're not going to know for sure whether the pregnancy is really affected. But I do want to put a plug in there that there are some people that go straight to diagnostic testing and they don't do a screening test first because they just kind of want to cut out the maybe types of tests and go straight to more of a definitive answer. But nowadays, especially, it's very common to do this stepwise approach.
What are the benefits of doing one of these invasive diagnostic tests?
So there can be several benefits depending on your specific circumstances. One is just to get that yes or no answer, especially if you've had an increased risk result come back from the screening test. So we can look for things like Down syndrome, Trisomy 18, all the conditions that we screen for can be tested for with diagnostic testing. Another benefit is you can test for more. Let's say that you're not just concerned about one thing based off your blood test result, but you just want as much information as possible, whether that be because you're an information seeker or you're at increased risk because they saw something on your ultrasound, but we can test for way more on a diagnostic test than we can on a screening test. And then another benefit could be it's your only option at getting more information. For example, if we have Sue and Tom from earlier and they're both carriers of cystic fibrosis, The only way to figure out if both of them passed it on would be to do diagnostic testing, or if you have a specific family history of a genetic condition such as Fragile X syndrome, the only option you might have would be to do diagnostic testing for those types of conditions. So there's a couple different options that you have for what type of diagnostic testing you want.
What are those? What are the types of diagnostic tests?
So great segue to our diagnostic testing options. There are two procedures that we routinely do nowadays, one called amniocentesis, one called chorionic villus sampling. And your gestational age will a lot of times determine which test that you want. So we'll take a look at both of them in a little more detail. So this is a diagram of chorionic villus sampling that we also call CVS for short. And just to orient you, here is a woman's back and here is a woman's tummy. And this is the baby here in the placenta. So the point of this procedure is to get a sample of that placenta because the vast majority of the time the baby and the placenta have the same genetic information. So we can sample the placenta to get a picture of baby's genetic information. And this way is showing what we call the transvaginal or transcervical approach, which involves taking a flexible catheter and guiding it up past the cervix and up into the placenta, and we use a little bit of suction to take a small sample. And it's all done under ultrasound guidance. Alternatively, this procedure can be done with a needle that goes through the tummy and accesses the placenta from the abdomen. And both procedures are done under ultrasound guidance. Both have the same accuracy. And this can be done anytime between 10 to the end of the 13th week of pregnancy, so pretty much the first trimester. Alternatively, there's a procedure called amniocentesis, and when you're farther along, there's more amniotic fluid, and we can just go straight into the amniotic fluid space and take a small sample of the amniotic fluid. Once again, it's done under ultrasound guidance, so we always know where the needle is and where the baby is, and there's no need for us to touch the baby with the needle, but it does have to go into the sac to get that amniotic fluid. And this test is a tad bit more accurate than the CVS, because the baby and the placenta should have identical genetic information. But as I mentioned, there's rare times when it's different. And the amniotic fluid is actually containing cells from the baby's body. So it's a little bit more direct of a sample from the pregnancy than a CVS procedure. But either way, they're both very accurate, and they both have risks associated with them because they're both invasive in one way or another. The risk of complications can be minor, such as mild cramping, bleeding, or spotting. They could be more severe, like leakage of amniotic fluid, infection, and any of those complications can lead to miscarriage or pregnancy loss. But the chances of those complications is less than 1%, so they're unlikely to occur after a procedure.
Laura, can you explain to us why the invasive tests are more accurate than the screening tests?
Definitely. And as I mentioned before, we didn't put statistics up here, but if you look at the statistics, it can actually seem very misleading because you might see cell-free DNA, it's 99% accurate. And then because we never say 100% in medicine, you might see the amniocentesis, it's 99% accurate. So why would anyone put a needle in their tummy if they can do a blood test that's 99% accurate? But like I said, statistics can be misleading. So when we're doing a blood test, whether it's maternal serum screening or cell-free DNA screening, we're looking at baby in combination with mom through mom's blood. Whereas if we are getting a sample from the placenta or the amniotic fluid, we can literally make this picture of your baby's chromosomes and count them directly to see, is there an extra chromosome or a missing chromosome in that pregnancy? We're not looking at baby through mom. So it's going to give you a much more definitive answer as to whether a baby has a chromosome condition or not. And this is the most basic testing that we perform, what's called the karyotype, and that's literally a picture like this where we just count them up, make sure there's no extra missing chromosomes, make sure there's no big chunks of the chromosome missing or duplicated. But we can do many more tests depending on the clinical scenario beyond a karyotype. One additional test that's pretty common is what's called a chromosome microarray. And this is essentially a zoomed in version of the testing. So we can pretty much zoom in on the chromosome so that there's a little teeny tiny piece that's duplicated or deleted. We call those micro duplications or micro deletions. This test can pick it up, whereas the karyotype might not pick it up. And then if there's other testing, depending on your family history, your ultrasounds, et cetera, there's additional things we can always add on. But I think it's worth mentioning now that the more we look at genetic information, the more likely we are to find uncertainties. Because as smart as we've gotten in the past few decades, we still don't know everything about our genome or genetic information. So, for example, the Chromosome Microarray might come back showing we found something. There's a deletion of part of chromosome 11. And we might have never seen that same deletion in anyone else. So that deletion could just be normal variation. It could be something that makes your baby unique, but not abnormal in any way. Or it could be a yet defined genetic syndrome that has health problems associated. We just don't know that yet. Or maybe we find something that has been described, but only a few times, and maybe the kids have different outcomes slightly, and so we're not sure exactly what to tell you about your child's outcome. So there is the chance with any genetic test for uncertainty, but that's not really uncommon with pregnancy in general. For example, if you have an ultrasound at 20 weeks and they're doing the anatomy scan, they might find something that they can't tell you exactly what that means. So with pregnancy in general, there's a possibility of uncertainty, and often there is uncertainty. But the more genetic testing you do, the more likely you are to uncover some uncertainty.
So as good as these tests are, it sounds like there can be some uncertainty both with screening and with diagnostic testing.
Pretty much. I wish it was more simple. It's job security, I guess, that it's not more simple. But I think it's worth seeing the different types of uncertainty. Screening tests and diagnostic tests have it. But when we're talking about the screening test, the uncertainty is whether this finding is real and actually exists in the pregnancy. So Down syndrome, for example. You can have a positive result and have a baby that absolutely does not have Down syndrome. Whereas the uncertainty that we get with some of the diagnostic testing is more, we know it's real. We know that the baby has this. We just don't know what exactly that means for the baby in terms of prognosis and outcome. And as I mentioned before, even with a straightforward, slam dunk diagnosis of Down syndrome, which is very easy to do with an amniocentesis, there's still uncertainty surrounding that type of diagnosis, given that we can't predict where on the spectrum a baby will fall. So diagnostic tests have a different type of uncertainty than, for example, a screening test, but there's certainly, the ability to have uncertainty with either one.
Well, it sounds confusing. It's really a lot of information. Tell me something. Do I have to have genetic testing during pregnancy?
Absolutely not. There are many options here, but one of the options is not doing any genetic testing at all. Some people feel like that information would be helpful to know ahead of time, and they'd rather know earlier in pregnancy than at delivery. And they might want to know because they want to prepare, whether they prepare financially, emotionally, prepare their families. They just don't want to find out at the end of the pregnancy. Other couples might change something about their pregnancy if it's diagnosed with a genetic condition. For example, they might change the place where they deliver. They might not continue a pregnancy and terminate the pregnancy for a genetic condition, or they might make an adoption plan. On the other hand, some people, they just don't want to know, and they'll figure it out at delivery, and knowing ahead of time might create anxiety, it might create undue stress, it just might not be worth the information, or they don't want to risk anything to find out, or they're concerned about uncertain results with the screening test. So there are people that have all different walks of life and values and desires. And so this should really be based off an individualized conversation regarding your specific values and desires.
Well, it's a lot of information. And it's, on the one hand, these tests can offer parents reassurance, the chance to prepare in the way that Blair was just talking about, possibly the chance to change pregnancy management and decision-making around your pregnancy, including the option of termination. And at the same time, the testing can result in uncertainty, risk, and for some people, the anxiety is a bigger issue than the opportunities to change the management of their pregnancy. So there's really a lot of different ways that people can use this information, and what test is right for them is going to be a personal decision. So Blair and I thought that maybe the easiest way for people to learn more about how these tests are used would be to look at some scenarios of individual women coming in for genetic counseling and hear about their personal stories and how that might affect their decision making during pregnancy. So we're going to run through a few different scenarios. The first one is Amy. Amy is a 32-year-old woman with one child, a healthy 2-year-old girl. The first time around, Amy had something her doctor called integrated first and second trimester screening plus a nuchal translucency. And it showed everything was fine. Amy is a high school teacher and her husband is an accountant. She's 8 weeks pregnant. She feels sicker with this pregnancy and is very concerned that it might mean something is wrong. Although her doctor has been reassuring, she and her husband are both anxious to get any information they can on this pregnancy. Thoughts, Blair?
Yeah, so Amy is at low risk for a chromosome condition based off of her, normal family history and her age of 32. And I would first want to just reassure Amy that just because she's more nauseous and hasn't felt as well does not put her at any higher risk because of that. So while it doesn't put her at actual risk, it might make her more anxious and she might seek more information because of that anxiety she's feeling. Given that she's low risk, it's a perfectly acceptable approach to do integrated screening again. It gave her reassurance last time. She's familiar with it. It's available this time around, and it'll probably be covered by insurance. Given her anxiety, though, she might want to jump to a little bit more accurate test with cell-free DNA screening, but it might not be covered by insurance, so that could be a boundary for her. But depending on how anxious she is, I would love to have a conversation with her and discuss, how much do you really want to know? Because diagnostic testing might be something that Amy decides to shoot for to avoid the uncertainties of screening and be able to test for as much as possible. So Amy could really go any direction here. It depends on so much on that personal discussion that we have with her.
Yeah, if they're really genuinely first priority is to get any information they can get, then for them, diagnostic testing might be the way to go. But many people feel very comfortable starting with screening testing and stopping there if they get a negative result. Let's move on to the next scenario. So this is Yvonne. Yvonne and Joe have been trying to have a baby for 3 years and are now both 38 years old. 6 months ago, they made the difficult and very expensive decision to do IVF, and they were devastated when the first round failed. Now, after a second try, Yvonne is 10 weeks pregnant. Of course, they're thrilled. They would like to know the sex of the baby and are curious about testing, but are very concerned about doing anything that might put the pregnancy at risk.
Yeah, this is a common scenario where people have gone through so much, both emotionally and financially, to get pregnant. And so they may be more likely to not do an invasive test because of those risks of miscarriage after all they've been through. Given that she's 38 and therefore cell-free DNA screening would likely be covered by her insurance, plus she's got an increased risk for chromosome abnormalities, I wouldn't be shocked if this couple went through or decided to go with cell-free DNA screening. Maternal serum screening is probably not the best choice for her, given that there's more false positives, especially in women that are over 35 years old. But cell-free DNA screening is probably a better option for her.
Yeah, one thing we might mention is that cell-free fetal DNA screening, the screening of the fetal DNA, is more accurate or less likely to be a false positive in a population that is higher at risk. So actually the fact that she's 38 years old means that if she gets a positive result on cell-free fetal DNA testing, it's even more likely to be genuine and not false positive. So that might be a really good option for her. Let's move on to Annabelle. Annabelle is 12 weeks pregnant with her first child. She has 2 sisters and 1 brother. She describes her brother as slow and notes that he still lives at home with her mom and dad at age 25. He was in special classes in school. He has trouble with reading and math and walks sort of awkwardly. Her parents brought him to many doctors when he was a child, but never got a diagnosis. Annabelle will be a single parent and is very concerned about having a child with disabilities. She wants to know if there's any tests she can do that will rule out the risk that her child might have problems similar to those of her brother. Claire?
So this is one of those where I'd like to go back in time and see Annabelle before she got pregnant. Because in an ideal world, we could have discussed ways to get her better information during pregnancy. Because without knowing what her brother has, it's really, really difficult for us to provide any reassurance about her current pregnancy and offer testing. But let's say that we had recommended her brother go to see a geneticist to see if we can find a diagnosis now. Because if he, went to the doctor as a child and this kid's 20-something years old, there's a lot of advances that have happened in the last decade. So if we could get a diagnosis on him, I could provide her more concrete information about her risk and testing options. Or even let's say that the brother, lives in Mexico and he's not available for any genetic testing. We could at least offer her some sort of screening, such as maybe Fragile X screening, which is a routine thing that we screen for when there's a family history of intellectual disabilities. So we could still offer her that. But given that we don't know what he has, the routine testing options we talked about earlier, like for Down syndrome, are really not going to provide her reassurance, since they probably are going to test for a different condition than what her brother has. But Laura, do you think that because she's grown up with someone with special needs, that she would be more likely to do testing just because she knows what it's like to be with a brother like that?
Yeah, well, I think it's one of the conversations you would have with somebody, because it sort of depends on whether the experience of having her brother and knowing him makes her more or less comfortable with the idea that she could have a child with a disability. If somebody is really, really concerned, then they might want to go to diagnostic testing where they could test for a greater range of things. Even though, as you say, in this case, we wouldn't know for sure if that was ruling out what's affecting her brother, unless we could get more information on him and do it really quickly, because at 12 weeks, you don't have a lot of time. So again, we'd be looking at the same two options of, does she want to go to diagnostic testing or does she want to stop with screening? But she should understand that the prenatal screening is really not going to look at what's going on with her brother. It's not going to say anything about her risk of having a child with something that's in her family history. So let's go on to our next slide. This is Joanne. Joanne is 40 and pregnant with her fourth child. Her oldest is now 12 years old. Joanne had prenatal testing when she was pregnant with her 12-year-old and was told that there was an increased chance that the baby would have Down syndrome. Although she was not sure how she would use the information, Joanne ultimately, after a certain amount of agonizing, decided to have an amniocentesis. The test showed the baby was not affected, but the weeks leading up to the tests were difficult for her, and she didn't really relax until the baby was born. The experience was so upsetting that in her next two pregnancies, she decided not to do any testing. Now at 40, she knows the risks are higher and would consider testing. What do you think you might discuss with Joanne Blair?
Yeah, for Joanne, I really feel like, once again, maternal serum screening is not ideal for her. It sounds like that's what she had 12 years ago when she was not at increased risk and it gave her a false positive. And now that she's 40, she's even more susceptible to a false positive. So maternal serum screening is pretty much out. But if she wanted to pursue a screening test that had no risk involved, cell-free DNA would be a better option for her, given the lower false positive rate. But given that she's gone through a false positive before, even if I tell her there's a less than 1% chance she'll get another false positive with this new and better test, she might be nervous about it and decide to skip straight to a diagnostic test. Just because, she's had an amniocentesis before, maybe she's less nervous about it, or sometimes they're more nervous about it because they've had it before. So it really depends, I think, on that experience a lot. But she also might be someone that, after hearing all the pros and cons about the risks of invasive testing, about the potential for a false positive, she might go back to her old strategy and say, you know what, I'm just not going to do any testing and I'll just take my chances. And part of that has to do with what she would do with the information, and that's not clear from this vignette. But there's a lot of factors that play a role in these types of scenarios.
Yeah, I think it would sort of depend on why she decided not to do any testing with the other two pregnancies. Was it because she didn't really think it would be useful for her, and so she didn't want to go through that anxiety, that she wouldn't make use of the information? But she says she's curious she's more motivated about testing now. So maybe she really does want to know. And I think you're right. If she does want to know, then cell-free fetal DNA testing really might be a better option for this woman. Because at age 40, it's a much, much lower chance of her getting a false positive, if that's the thing that's really bothering her.
Mhm. And I think it's actually something that we really didn't talk about because this webinar is more on genetic testing. But one thing I hear a lot of patients coming in and saying is, I'm just going to do the ultrasound and I'm just going to rely on that. And if everything's normal, I feel fine and we'll just stop there. And for certain conditions, that's a great approach. Trisomy 18, for example. Almost all of those babies have abnormalities seen on a 20-week anatomy scan. Down syndrome, on the other hand, we miss approximately half of babies with Down syndrome on the ultrasound. So if you're truly wanting to know ahead of time if the baby has Down syndrome, the ultrasound's not going to get you nearly as much information as a test like cell-free DNA screening that can screen with 99% accuracy, or an amniocentesis that can pretty much tell you with certainty. So we didn't really focus on ultrasound for this webinar, but it's important to know that it's helpful, but not going to rule out these conditions by any stretch.
Yeah, these sort of subtleties are why it's really helpful for people to have that conversation with their caregiver, or the if it's the genetic counselor or the OBGYN, because it comes down to balancing a lot of different possibilities and some personal options about how you want to use this information. Let's do our last scenario and then we can get to some questions. This is Marie. Marie is a special education teacher and she's 35 years old. She's informed of her increased chances for chromosome conditions based on her age, and she reports that she is a little concerned, but she's more concerned about invasive tests she'd heard about possibly causing miscarriage or inaccurate information from testing. Marie would like to know before birth if her baby has a genetic condition, if and only if it will help her take care of her baby. But she doesn't see the benefit of testing, just to know.
So my first gut instinct about Marie is that she probably doesn't need prenatal screening. She seems like she's reassured, but she has a little bit of concern about the possibility of a chromosome condition. But it sounds like she's far more concerned about the risks of invasive testing, or the risk of inaccurate results with screening testing. So based on this, it might be one of those times where we talk about how the limitations of screening and testing outweigh the benefits. She's also a special education teacher, so I wonder if the need for preparation isn't as important to her, since she feels more prepared given that she takes care of these kids every day at work. On the other hand, though, sometimes people that have a lot of experience with children with special needs are desire a heads up even more because they do know what these families have gone through. So if she did actually want testing, I can see her wanting a test that is more accurate and has a less chance of a false positive, so cell-free DNA screening. Or, if she wants just to know for sure and just cut straight to the chase, diagnostic testing will help her and give her that ability to test for way more genetic conditions, since she knows probably from her experience that it's not just Down syndrome. There's way more out there.
I think some people come into genetic counseling and they say, I know for sure that I'm never going to terminate a pregnancy, so why would I want to do any testing? And the message to them is maybe they don't want to do any testing, but for some people, they find that knowing in advance is helpful, even if they're going to use it for pregnancy management or just preparing themselves. But it's true that there's less reason to do it if you're absolutely convinced that you're not going to use the information and you don't feel like it's going to help you get ready. So are you ready to take some questions?
Let's do it.
Great. Okay. So our first question, what would be a good test for individuals who know a limited amount of their family history or have been adopted in? What do you think?
That's a great question. And the good thing about carrier screening is that we offer it to everybody, and most people that have a recessive condition running in their family don't even realize that they have it. So family history is not a super essential thing for carrier screening. And then most of the other testing options that we talked about today are really for the sporadic conditions. So while it would be really nice to know whether you had a family history of a birth defect or intellectual disabilities, you can still take advantage of pretty much all the testing that we talked about on today's webinar. What do you think, Laura?
I agree. I think not knowing your family history, no, it really shouldn't make any difference for this type of testing. One thing that's probably really useful for you is the carrier screening. And the best time to do carrier screening is actually, preconception, before you get pregnant. But either way, that's one that's one thing I think that would be even more important for somebody that didn't know their family history, because a lot of that,
Mhm.
as you said, goes silently. But obviously in some families they know they have a history of cystic fibrosis or sickle cell anemia or whatever, and so you're at a disadvantage if you don't start with knowing that family history.
Mhm.
um, our next question: why does the maternal serum screen not work in the 14th week? Why is it only 11 through 13 and 15 through 21? That's one for you, Blair.
So that's just the way that they validated. Without getting into a more complicated answer, they just know that the first trimester screen is most accurate between 11 and the end of the 13th week, and the quad screen doesn't become. And ideally, the quad screen's most accurate point in time would be 16 to 18 weeks, but it can be done as early as 15 and up to the end of the 21st week. There are some labs that will take the sample at 14 weeks, but it won't test for all of the conditions. So it's just a dead week, and I'm not even sure historically why they do that, but that's how it works. And it's probably because it's less accurate in that 14th week. So not a great reason.
At what age does your pregnancy become high risk? Well, this is a very subjective thing, right? That's not technically high risk, but there are certain ages
Yeah.
when pregnancies ramp up a little bit in risk.
So it's metaphorically just aligned. So there is a risk for Down syndrome at age 34. There is a risk for Down syndrome at age 35. And it's not like the risk jumps up incredibly high from 34 to 35, but 35 has traditionally been the risk cutoff where we start discussing this increased risk more. That's kind of fallen by the wayside. That was something we used more back in the day when we didn't know how else to screen for Down syndrome. So we just said, all right, let's just talk to you guys that are 35 and older, and you guys 34 and younger, you're off the hook. But when you look at the number of people that are pregnant, there are far more 34-year-old and younger people that are pregnant. So the majority of people with Down syndrome are actually born to that population. So we missed all of those pregnancies because we just ignored them. Nowadays, like we said, offer screening for Down syndrome to everyone that's pregnant. And these blood tests do a much better job of putting you in a high risk or low risk category than age ever did. So I don't really emphasize age as much as I used to, but insurance companies still look at it. That's why I mentioned that, and sometimes coverage depends on your age. And I will say that once you start hitting 40, that risk, instead of going up a little bit every year, that risk starts going up much more exponentially. So the risk goes up every year. 35 is where we cut the line in the sand, but it's not like 35 is this, cutoff where you should be very, very worried all of a sudden.
I think there's one other thing that Blair and I have talked about that I know we both want to emphasize here, which is that we're talking about risk, because that's our job. But really, whether you're 35 or 40 or 42, most pregnancies result in healthy children. So even though the risk goes up, still by far the most likely result is that everything is fine, and most people who take these tests ends up getting reassurance. So that's easy to forget when all you hear about is this word risk. But the reality in any prenatal setting is that at all different ages, most people end up with a healthy pregnancy.
Absolutely.
Are there advantages to maternal serum screening, except that it is covered by most insurance?
So this is a hot topic. So what are we missing out by not doing maternal serum screening? Some people say that it's better because it's more established. With cell-free DNA screening, we have gotten some surprise results that we're not as sure of what to make of them because the test just hasn't been around as long. For example, there are times when the placenta has a chromosome problem that the baby does not. And so the blood test gets DNA from the placenta and the blood test comes back abnormal, but then the diagnostic test like the amniocentesis shows everything's fine. I don't think we maybe appreciated how common that placental fetal difference was until we started doing more of the cell-free DNA testing. So maternal serum screening is more established. It's probably going to give you more cut and dry results. Having said that, the false positive rate is higher, and so those are not cut and dry. So it's more established. Obviously, insurance, like you mentioned, is a reason. One other thing we also didn't mention is screening for neural tube defects, or what we call spina bifida. That's a birth defect that is included in maternal serum screening, but you can get that as a separate test in addition to your cell-free DNA test. So you won't necessarily lose out on that opportunity if you do cell-free DNA screening. And then finally, I'll put a plug in. There has been some evidence that some people with more rare chromosome abnormalities will end up screening positive on a maternal serum screen. And so if you get a positive maternal serum screen and you do a diagnostic test like an amniocentesis, you might end up unearthing a really rare chromosome condition that cell-free DNA screening might have missed. So there's, it's not designed to look for more rare chromosome conditions, but that could be a benefit of maternal serum screening.
The other thing I'd like to mention that hasn't come up yet is that cell-free fetal DNA screening, the DNA screening, doesn't work for everybody. So there are cases where we get not a positive result or a negative result, but just no result on screening. And some people are at, I think twins, fill in here, Claire, people with higher BMIs and so on are more likely to end up with a no result. So there may be people for whom the hormone test is, the maternal hormone test is going to be a better option.
Right, and there's some women that actually have a genetic condition, for example, a chromosome abnormality, and her DNA is also in her blood. And so there's certain times where if you have a genetic condition that you might not be able to do maternal serum screening, or excuse me, might not be able to do cell-free DNA screening because your DNA is affecting the results. So there are those unique times, or there's certain medications that we found, like Lovenox, that might impact the cell-free DNA for some reason. So there are going to be at times, that's a great point, Laura, where we can't get results or the results are unclear because of some other reason, where maternal serum screening might be a better option.
I think we can take one more question here. This is a great one. I'm 32, my husband is 47. I'm concerned about possible mutations from having an older father. I'm not pregnant yet, but I am interested in having all the information possible to make informed decisions. Question 1, would a diagnostic test be my best option? Question 2, how can I find a genetic counselor or OBGYN that is informed about these options? Let's start with 1. So, would a diagnostic test be your best option?
This is a fantastic question because it brings up dad's age as well. We've only really picked on moms so far. So dads who are over the age of 40, that's kind of the line in the sand for dads, don't have an increased risk for chromosome abnormalities, but they do have an increased risk for what we call single gene disorders. In our genetic code, we've got about 3 billion letters that make up our genetic information. And as men get older, they might acquire more changes in those letters. So it's not an extra chromosome, it's just a single change in a single letter. And usually when that happens, we've got like a DNA spell check that goes through and fixes it. But as men get older, that spell check just kind of, gets a little bit lazier and a little bit lazier. So the thing about these single gene disorders is they are really, really hard to test for, because if you can imagine spell checking 3 billion letters, it's a really tedious and expensive type of test. So the good news is these single gene disorders in general are very, very rare. So even with an increased risk at age 47, these conditions usually have a prevalence of well less than 1 in 1,000 births. So given the low prevalence, we don't recommend any particular screening or testing for a dad that is over the age of 40. Ultrasound is really helpful. So let's say your ultrasound shows the sign of a specific single gene disorder, then we would definitely talk about diagnostic testing and target that one specific condition that we suspect based off the ultrasound. But let's say you do your 20-week anatomy scan and everything's stone cold normal. I mean, it's really like shooting in the dark if you do a diagnostic testing as to what we can test for, because a chromosome karyotype and a chromosome microarray will not detect single gene disorder. So that was a long answer. Short answer is for dads over 40, we don't really recommend any specific testing in the absence of an ultrasound abnormality. And because you're 32, you could certainly pursue maternal serum screening, cell-free DNA, or invasive testing.
And I'm going to take the easy one. Question 2, how can I find a genetic counselor? Go to the website of the National Society of Genetic Counselors, and there is a button, Find a Genetic Counselor. So we can definitely help you there.
Laura, there are genetic counselors in many of the major metropolitan areas, but there are some people that don't have geographic access to genetic counselors. But there are many genetic counseling services that are available by phone, so you can do telegenetics, and they could even set up something like we're doing, where there's you can also view the genetic counselor. So even if you're not in a city where there are physical genetic counselors, there's telemedicine that can help with that.
So thank you all for joining us. We're out of time. If there's other questions, we'll try to answer them by text. And hope this has been helpful. And we've really enjoyed being here with you. Good night.
Night.